Thank you. I have such a pride to get to stand here at INHSU again, and I appreciate Mim's presentation for putting in the word belief. I feel like it's really a core essence of so much of what all of us are doing. My name is Meghan Morris. I'm an associate professor of epidemiology at UCSF, and today I'm going to be presenting findings from the No One Waits study. It's focusing today on the pharmacy integrated element of our test and treat model, which was key to facilitating hepatitis C treatment at the point of diagnosis for marginalized communities. There we go. And I'm really presenting this on behalf of an amazing multidisciplinary team, including pharmacists, nurses, physicians, epidemiologists, and members of the affected communities. And I would like to acknowledge our support from Gilead Sciences for the funding for this investigator-initiated research and for the infrastructure from NHEPCSF. We conducted this study during the height of the pandemic, and I will say that NHEPCSF's infrastructure in San Francisco really allowed us to leverage many resources. Oh. Okay, hitting the right button now. So despite the availability of curative DAAs, hepatitis C treatment. That's what I'm hitting. Yeah, I'm hitting the green one. The big green one, right? Yeah, okay. Do you mind just going back one slide for me? Thank you. All right, so I'm going to restart on this one. Despite the availability of curative DAA, I'm really not touching anything. Oh, no. All right. Despite the availability of curative DAA therapy, hepatitis C treatment initiation, oh my gosh. Oh. Okay, well. I'm going to just try to speak fast and hope that the timing on this presentation works with me. I apologize for this. This has never happened. All right, so in San Francisco, where I live, hepatitis C virus, or Hep C, disproportionately affects marginalized communities. And of the roughly 12,000 people estimated to be living with active, untreated hepatitis C, people who inject drugs represent just 3% of the population and account for about 90% of infections. And our Black and African American neighbors represent 5% of the city's population, but 25% of the reported cases. These disparities highlight the importance of really targeted treatment that is centered in the community. There's a number of barriers to initiating hepatitis C treatment, which we can group into 3 categories: person level, clinical level, and system level barriers. At the socio-individual level, people are going to experience stigmatization, mistrust of the medical system, and also have competing priorities. The clinical barriers include incomplete confirmatory testing, providers' lack of knowledge or discomfort with treating hepatitis C, especially in the case where there's comorbidities present. And at the system level, navigating the complicated health system, having little comprehensive care, insurance requirements, and high drug costs are just some of the barriers there. And so really the premise of the NOW model is believing that a test and treat model can overcome many of these barriers. So the No One Waits study was designed to address a multitude of barriers through a point of diagnosis treatment model delivered in a non-clinical neighborhood setting. This was a single-arm clinical trial conducted between July 2020 and October 2022 in San Francisco, focused on people who inject drugs and those experiencing homelessness, who were eligible for a simplified hepatitis C regimen. A critical component of our model included the provision of a 14-day starter pack of Softvel, which allowed for us to actually start on the same day that diagnosis was made. We also had a staff-facilitated telemedicine element, which is another key component of our model. And this allowed us to address geographic and transportation barriers, but also technology and medical mistrust. We recently published a paper in the Journal of Healthcare that outlined more on our staff-facilitated telemedicine model. All right, so I'm going to talk through this slide for a few minutes here. This is really our pharmacy team workflow, and maybe the IT person can help me slow down my slides. Do you mind? Thank you. Can you go back? Yeah. One more. There we go. You can stay here for a minute. Thank you. The pharmacy team worked closely with the research team to ensure a seamless workflow from the point of diagnosis. Okay. From the point of diagnosis to the delivery of medication. And so I'm going to walk through each of these columns in a moment. So the first is intake. At the point of intake, baseline participant information was gathered, which included verifying their identification card, health insurance details, income level, and household size. This information was needed for completing the steps related to insurance verification and prescription processing. After that was the prescription itself. So after receiving the results of the Hep C RNA test and confirming the participant's eligibility, the clinician electronically electronically prescribed the soft valve medication, and the pharmacy team was immediately notified through secure messaging. To avoid further delays, participants were given, as I said before, a 14-day starter pack of soft valve at the same visit, allowing treatment to begin while the pharmacy team worked on securing insurance approval for the remainder of the treatment course. I hope you're not getting motion sick. I'm sorry. So the next step is benefits investigation, and this is the one that had the largest range of time. It took between 5 minutes and 7 days. Here, our pharmacy technician took the lead in verifying the participants' insurance coverage and enrolled them if they were uninsured. This step was essential to identifying potential hurdles early, like prior authorization and requirements related to requirements or copays. The next step was the prior authorization step itself, and this was really the most hands-on and demanding step for our pharmacy tech. For participants who are covered under certain insurance plans, especially managed Medi-Cal, prior authorizations were required before insurance-covered soft valve could be dispensed. And the pharmacy technician completed all the necessary information, including providing the fibrosis data, also providing any previous treatment records to the insurance carrier. And this was done really in conjunction with our research team. There was a lot of back and forth with information that needed to be shared there. And this is a necessary step that I just really want to emphasize, because this was the step where most administrative barriers could have presented themselves that would have left people from the ability to actually transition to insurance-covered medication. The second to last column is the insurance approval step, and this was between 24 and 72 hours. Once the prior authorization was approved, the pharmacy team received a notification, and the participant who required it, the team then enrolled them in a copay assistance program that was really, really essential in order to overcome any nominal amount of copay. And the last step was the medication delivery. This was really coordinated, again, with our research staff, where the pharmacy and coordinated with our team. We went once a week, usually picked up a batch of prescription medication, brought it back to our neighborhood site, and it was able to be residing there until the person was able to come by and pick up their medication. All right, we can hopefully proceed now. Thank you. So between 2020 and 2021, as I mentioned, we had 87 people who were enrolled in the NOW study. The majority of them were currently injecting drugs and had incomes below the federal poverty line. 61% of the people were unsheltered at the time of undergoing treatment. And I just want to note that further results, including the primary endpoints, are available in our 2023 publication. So let's move over to the results related to the pharmacy. So a significant success of the study really was our ability to transition participants from study-provided medication to insurance-covered treatment. 70% of people moved to insurance-covered DAAs within 2 weeks. So within the time that we had that starter pack, we were able to move them over. And 90% of all participants actually transitioned before completing the 12-week course of treatment. In this slide, we're going to see some of the key barriers that participants did face in obtaining insurance-covered DAAs. And so first, managed Medi-Cal plans require DAAs to be dispensed by specialty pharmacies, which often included some delays. As we can see from the graph, the most significant reason for the delays was the pharmacy consent process, which required an actual written form most often, and that was impacted by 9 participants that were impacted by that. Additionally, prior authorization requirements created obstacles, although 70%, as I already mentioned, were able to transition to insurance-covered care within the 2 weeks. For 6 people, the lack of insurance coverage led to delays, and 4 people faced issues related to out-of-network insurance, specifically folks who were covered by private insurance. And missing information also delayed transitions, though this was less important for many of them. So although the Medi-Cal insurance had no copays, 9% of people, primarily those with Medicare, did face small copays. It was around $4, but for these 4 people, they were unable to pay those $4. And our pharmacy team actually were able to enroll them in copay assistance programs, and then when that didn't cover the amount, some of them didn't, our study actually paid through study funds. So I'm going to just shift and kind of zoom out for a minute because since the study was completed in 2022, we have some important changes that have happened with policy that have streamlined things. So changes specifically within the California Medicaid policies have eased some of the barriers to hepatitis C treatment. Specifically, prior authorizations are no longer required for DAAs under Medi-Cal, and community pharmacies can now dispense these medications. So those are 2 things that really added a lot of time and effort from our pharmacy team that are now removed in California. Additionally, DAAs no longer need to be prescribed by subspecialists, and which opens the door for broader accessibility. So I want to actually talk just for a moment about some significant insurance barriers to DAA access that still remain nationally in the United States, because obtaining prior authorization and coordinating medication deliveries from specialty pharmacies took between 1 and 2 weeks for most of the people in the NOW study. We need to really address these policies in order to make this accessible. And upfront provision of DAAs in the future point of care diagnosis model really would help circumvent all of these, and so I want to really draw attention to the importance of that 14-day starter pack. And then lastly, the removal of prior authorization and the removal of copays, in addition to fees related to any necessary lab work. I hope to have some of that happen at the federal level so that we don't have these variations at the state. So in closing, I just want to leave you with direct partnership with experienced pharmacy team played a critical role in transitioning participants to insurance-covered treatment quickly and advocated for person-centered solutions for copay and medication dispensing barriers. And I'm going to just close by encouraging you to attend 2 of the posters that are also providing some NOW study data, 212 and 213, and a photo of a certificate of treatment completion that each of the 67 people who completed their 12 weeks of treatment received with a photo. And for many of them, this is the first certificate that they'd ever received. And when presented with the certificate, they really recognized the magnitude of that moment, both for themselves personally, but also for their community. And I think that many of us in this room can really resonate with that feeling of change and impact. So thank you so much for your time, and for hopefully anyone who has motion sickness, I'm really sorry about that. I don't know what happened.
Thank you so much. And you are a hero, no? Going through all this. But we have two questions.
We have time.
We have time
Okay.
for questions. Okay.
Thank you.
The first one is from the audience. In the pharmacy team workflow between steps 3 and 4, what was your strategy to minimizing lost follow-up?
Yeah, so I really didn't emphasize enough the importance of the team and just our dedication to being with people human to human. We really are trying to provide care in the most compassionate way. And I have a number of photos of us creating bags with masks, and this is in the middle of COVID where we were all stuck in isolation, and many of our participants actually moved over to housing, and we had created plants for them and cards for them, and it truly was a neighborhood space. And I think that that is the essence of what made this successful, because we were committed to creating that space in a way that suited everyone who walked in as much as we could as researchers. Our job there was to collect rigorous data, but we wanted to do it while really ensuring that we're centering people's humanity.
And the second question from the audience is, how were patients tested for HCV? And what was the average time between testing and diagnosis? Is there lost to follow-up data available?
Yeah, I'll really encourage you to read the endpoints paper in JAMA Open. It goes into detail about some of the steps between testing. We did antibody testing, and then we did reflex testing. So we actually chose to make this as real world as possible, and at that time, point of care testing wasn't possible for RNA. And so we were reliant on that 1 week turnaround time in order to have people come back, so that we lost a few people, 17 people, I think, specifically, at that point. And then the other drop-off was 23 people who we weren't able to get a successful blood draw from. And we have an incredible phlebotomist, and so that says a lot. So those 2 points were really important in order to overcome that barrier for a true test and treat model. And so it was reflex testing. Hopefully some of that will be overcome with our new point of care RNA.
Thank you so much, Meghan. Meghan, one more thing, because we actually do have a couple of minutes. We're doing really well for time. And I might have missed it, but just to clarify a couple of things, because I think some of this is very detail-oriented, and without the details, we can't fully replicate the model. When you say donated,
yes,
that compassionate, and then, maybe we'll start with that.
Yeah, so this study was made possible because it was funded through Gilead Sciences as an investigator-initiated research study. And with that, through that partnership, we were able to have donated starter packs as part of our study design. And that was a 14-day course that we were able to start everyone on at that point when they were diagnosed, and they said, yes, I would like to start treatment. We gave them 14 days of medication. We also designed the study so that they came back every 14 days. That was some data that we had and others have shown that that's a really sweet spot for people to be able to come back from this community and have ability to have their medication dispensed in an allotment that they could keep secure and safe. So we were able to keep people on donated medication for the duration of treatment if they needed to be. But as I said in this presentation, 90% of the folks, 87, were actually transitioned to insurance-covered care. Again, wanting to try to show a model that would be able to be scalable for a real-world setting.
Fantastic work. Thanks so much.
Thank you.